Welcome to the Counselor's Soapbox video channel, Learning About Alcohol, Part 36. These are other topics a substance use disorder counselor needs to know about. I cover this in my alcoholism studies class, and each of these topics is presented elsewhere in the drug and alcohol counseling series in more detail. The treatment field is about a lot more than simply getting people clean and sober. The drug and alcohol counselor needs to conduct education. Some of that education is aimed at the public in general, and also some of it is educating future professionals. Each counselor, as they move through their journey, has a responsibility to pass on what they've been taught to the next generation of counselors. Also, counselors should be aware of the topic of prevention. While it's not strictly treatment, it's important to understand the difference between primary, secondary, and tertiary drug and alcohol treatment. How do we define prevention? Recently, there's been an increase in the amount of funding available for prevention programs, and so we need to know what they do and which ones are effective. Prevention programs are typically divided into three types. Primary prevention, which are attempts to keep substance use or abuse from occurring in the first place. These are directed at the entire population, whether they've ever experienced substances or not. Secondary prevention is to prevent problems when they first appear. An example of this might be students on a high school campus who are caught with cigarettes or marijuana, or an underage person who is found with alcohol in their possession. Tertiary prevention is treatment for those with a substance use disorder from getting worse. Examples of this might be a first offender DUI program, or someone who is arrested with a small quantity of drugs and sent to a drug program rather than sent to jail. In designing a prevention program, there are three basic models that are used. One is the socio-cultural model, and this is an effort to teach people about such things as acceptable drinking and unacceptable drinking. Drinking with meals is a low-risk behavior, so you teach people what is acceptable drinking. Drinking utilitarian, getting together simply to drink, would be a high-risk behavior. Another prevention model is the disruption of consumption model. As the average consumption increases, so does the number of heavy drinkers. The more heavy drinkers, the more problems. Reducing consumption is a goal of this model, and consumption is reduced by making it more difficult to drink, raising minimum ages, increasing the price through taxes, and reducing the hours of sales. Another model for prevention is the prescriptive model, telling people, do not do it. Examples of this were the institution of prohibition, where the sale and manufacture of alcohol was made illegal, or the Just Say No campaigns. NIDA, the National Institute on Drug Abuse, publishes principles of drug abuse prevention. Their principles include increasing protective factors and reducing risks, strengthening families, improving social, emotional, academic skills, and success in education, and having smooth transitions and provide prevention at multiple places. Other NIDA principles of drug abuse prevention describe a successful program as adapting programs to communities without losing key elements, long-term repeated programs staying on message, parent training, teacher training in effective management, and involving children and teens in the design and operation of the programs. Some current topics of discussion and prevention include ways to involve parents in the program, teaching resistance skills, multimedia, staying on the same message from multiple sources, and how to tailor the message for subgroups without losing the basic principles. Other current topics of discussion and prevention programs include talking about legal tolerated drugs such as alcohol, tobacco, and increasingly marijuana as possible gateways to other more advanced drug use, risk reduction or harm reduction, and how to reduce advertising which has been aimed primarily at young children and young adults. One question prevention programs have to address is, do prevention programs simply amount to advertising for drugs? Efforts to teach people how to drink responsibly can in fact teach people how to drink. Some of the efforts to teach school children about tobacco and marijuana have in fact introduced them to more information about how to consume those drugs. So we have to be careful that prevention programs don't simply give the people we've aimed them at a longer list of drugs they would like to try. There's been disagreements in the prevention field about what works best. Drug resistance education, teaching people not to do drugs, or life skills training, teaching people how to have a happy and successful life without drugs. Some of the more positive and productive programs seem to incorporate both drug resistance education and life skills training. Some other prevention initiatives worth considering: social host ordinances, in which an adult serving alcohol to minors can be fined for each minor that consumes alcoholic beverages. The social host can also be responsible if that minor leaves the party and does something they shouldn't do or gets in an accident. There are worksite prevention programs, employee assistance programs, and so on. There are also college programs which teach drinking norms. Turns out that the average college freshman thinks that the average college student drinks a lot more than the average college student really does drink. There's also a modern recent trend towards harm reduction. Rather than trying to prevent certain drug use completely, the effort is to reduce the impact. So things like legalization, particularly of marijuana, but also of other drugs in small amounts. In some countries in Europe, there are safe injection sites where a drug addict can go to the doctor, get his drugs in a needle, go in a little room, inject, dispose of the needle, and leave. And that keeps the drugs and the dirty needles off the street. There are also social service programs called wet houses, where the people who are homeless, in order to get housing, don't have to give up drinking alcohol. They simply have to confine it to in their apartment rather than being out in public intoxicated. And another form of prevention initiative, harm reduction, is methadone maintenance, where heroin addicts are converted to a legal methadone dose which is prescribed, in which they go to the clinic to get usually each day. Alcoholism counselors, or drug and alcohol counselors, need to consider the various career paths that may be involved in working in the field. Many people who work as drug and alcohol counselors are themselves in recovery. In some areas, California is one, there is a system of registration where students take some classes, register with a registry, and then pursue certification where they get a certain number of supervised hours and pass an exam. There can be licensure. There's some question about licensing people with a small amount of education, a year or two of college, versus master's level people who have 6 years of college. And so there are increasingly advanced degrees, bachelor's or master's in counseling that are applicable. Also, many people who work in the mental health field, marriage and family therapists, licensed professional clinical counselors, licensed clinical social workers, people with PhDs or PsyDs are more and more moving into the drug and alcohol counseling field, so that a licensed mental health professional might specialize in working with clients who not only have a mental health challenge but also have a substance use disorder. Ethics are another subject which beginning counselors need to understand and study. The ethics there are general principles, but there are also specifics, and the specifics will depend on the code of ethics, the organization that you belong to. Some of the general principles are do no harm, confidentiality, that what someone tells a counselor should be held confidential, but in every situation there are some exceptions. For example, if a client is talking about killing themselves, or if the counselor learns about someone who is abusing a child, those cannot be kept confidential. That's the topic of mandated reporter. Many people who work in this field, most people, are mandated reporters, and if they learn about abuse of either a child, an elderly or disabled person, someone who can't protect themselves, they must report that. That's an exception to confidentiality. There are codes of ethics that are specific to various organizations or to various licenses, and they may vary in the details, though the general principles are the same. So, when asking what ethics you have to follow, it's what group do you belong to, but you can't evade that by not joining a group or by quitting a group. So you have to consider that if you're a particular licensed professional, you have to follow the code of the largest, the dominant organizations in that field, whether you're a member or not. Also, a topic that beginning counselors need to consider is managing multiple relationships. We used to say not to have dual relationships, but relationships come in a whole lot of shades, and so when is your relationship with someone too close? You both live in the same city, that's okay. You both live on the same street, that's okay. The client is your next door neighbor or dates somebody, one of your children or relatives, that's too close and you shouldn't be working with that person. So you have to manage all of these multiple relationships. We also, counselors need to learn about the curriculum that will be used at the program that they're working at, and they have to be stick to that curriculum, which is called fidelity to the model. There's also a thing called the National Registry of Evidence-Based Principles and Practices, a lot of different curriculum and methods of working with clients that have been tested to prove that they are really effective. Well, the general rule is everything that the client tells the counselor should be confidential. There are some specific exceptions to that. Danger to self, wanting to kill yourself, or to others, intent to kill someone else. Being gravely disabled, if your client can't feed themselves or clothe themselves, you can't keep that a secret. Mandated reports, child abuse or neglect, elder abuse, could also be financial abuse with elders, or disabled person abuse, all of those are reported. If the client enters their mental health as a defense, they say not guilty by reason of insanity, well, then the counselor will have to discuss that in court. If the client sues the counselor can introduce their records to show what they did in treatment. One of the key principles that counselors need to understand is informed consent. The counselor has to explain what's going to happen and what's confidential and what's not. So if the counselor must report, and it is not a generally recognized exception to confidentiality, then the client must sign a release before treatment begins. Examples of that could be criminal justice, if the client was referred by the court or parole or probation, and the counselor has to report back to them. The client has to agree to that, or the counselor can't see them. If CPS or another party referred a client and needs to have progress reports, the counselor must make those. Most programs will have a requirement, and the client will need to be informed and need to agree to the idea that if they use drugs or alcohol or some other thing while they're in the program, that will not be kept confidential. And counselors working with people in the military may have a duty to report military sexual trauma. While generally rape is not reportable in a private setting, people in the military who report that, there may be a requirement for their counselor to report that. And so counselors need to be aware of that, and clients need to be told about that. Another exception to confidentiality is if the client is using insurance, certain elements about what their diagnosis and their dates of treatment will have to be reported to the insurance company for reimbursement. Other ethical issues that a substance abuse counselor needs to be aware of: managing multiple relationships. There are different rules depending on your level of training and who you're working with about falling in love or engaging in sex with someone that you've met as a result of your employment. There's also employee-employer relationships. Counselors should not hire someone that's one of their clients to work for them, or should not go to work for one of their clients. That muddies the waters. And money issues. You shouldn't lend money to a client or borrow money from the client, those sorts of things. Other issues are scope of practice. There are certain things that each of the various professions who work in this field are allowed to do, and other things that are outside their scope of practice. For example, a master's level counselor or a drug and alcohol counselor cannot prescribe medication in most places. There's also a smaller thing or issue called the scope of competency. While it may be legal for you to do it, if you don't know enough about a particular issue. For example, in some places, substance abuse counselors might also see people with a gambling problem, but they should only do that if it's legal in their jurisdiction and if they have adequate training and supervision to do it competently. And counselors need to be aware of credit for writing and research. If you quote other people, if you report something someone has researched, you need to give them proper credit. Another issue counselors need to consider is counselor self-care. Burnout, originally called compassion fatigue when it was recognized in social workers, generally consists of 3 steps. First is exhaustion. The counselor finds that they are so tired that they physically or emotionally that they're not able to rest up over the weekend or over their time off. Second is becoming cynical, feeling that the people you're working with don't really want help or are not trying. And lastly comes the stage of self-doubt, where the counselor begins to think they're no good as a counselor. Counselors need to take good care of themselves to avoid burnout, and if they recognize any of these symptoms, they need to take steps, time off, rest, see another therapist to manage these. Another issue for counselors working with drug and alcohol clients is relapse. It's possible for the counselor to start to use or can resume use of either drugs or alcohol, which can be a serious problem when you're yourself abusing substances and working with clients who have that problem. And it can be very difficult for someone in recovery who spends all day talking to someone who is trying to quit using about their use. Lastly, life is a journey, not a destination. Remember that for many people, beginning as a substance abuse counselor may be the first step, and they may go on to work in administration, to become licensed master's level counselors, or may decide to move into some other social field or business related field. What's ahead on the Counselor Soapbox video channel? More videos on drug counseling, drug education, mental health, and wellness. If you've enjoyed this video, please click the like button below. Comments are always appreciated. And if you want to see new videos in this series, please subscribe. Thanks for watching. For more information, please visit my blog, counselorsoapbox.com. David Joel Miller fiction and nonfiction books are available on Amazon.